We are a group of students from G3042, Just Education, the Role of Higher Education in Disrupting Mass Incarceration. Our project title for this Grand Challenge curriculum is Healthcare and Correctional Facilities, where we aim to propose a partnership between University of Minnesota Medical School and the Minnesota Department of Corrections.
My name is Kenza, and I'm going to go into some of the main points about the general purpose of this program and why it would be so beneficial for those who are incarcerated as well as medical students at the University of Minnesota. For one, because incarceration has affected so many people, it's imperative to prepare future physicians through a program like this because it would allow them to become familiar with the reality of healthcare and ultimately give them the experience to help assist patients in their future careers that may have been impacted by mass incarceration. Another main purpose of this program is to promote education for future physicians on the health of incarcerated people, not just currently in prison, but long after, which this program would also help foster and create. And lastly, there is a real unawareness of healthcare in prisons, both in terms of actual care and health of those incarcerated. Prison itself impacts the health of people, and while it is important that physicians gain this knowledge, it is even more important to provide those in prison with quality health care they are not necessarily receiving at the moment, but do it in a way that gives them an opportunity to build relationships with people in the Minnesota community that can give them that care. Minnesota medical students would be a perfect group of people to do that.
Yeah, so as previously mentioned, we are really proposing a partnership with letters to each respective party and a real drawn-out proposal listing things such as, what both parties have to gain through establishing this type of connection, the current state of care, and, areas of improvement. And what really actually brought this to our attention was the COVID-19 pandemic. Because while the pandemic was and continues to be an ever-present threat to society, its effect across different communities has not and continues not to be uniform. And so here we saw that there was a major inadequate access to quality health care, which was really exposed in this incarcerated community, and we really saw this potential for this partnership. And while currently inadequate and absent, a partnership between the U of M and Minnesota DOC could go on to produce generations of amazing, caring, understanding, and really highly trained healthcare professionals for the incarcerated population for decades. So throughout this presentation, we will be providing some background information and context to this proposal, along with benefits and challenges that come with it.
So now we're going to provide a little bit of background information for why we felt that this is an important topic to discuss for our project. We feel that there is a critical need for unbiased medical providers and treatment, especially with the healthcare disparities that are faced by incarcerated individuals who typically have higher rates of medical and health challenges in comparison to the general population that usually has adequate access to healthcare, according to the World Health Organization. The limited health and medical services that are offered to prison populations contributes to the gap in socioeconomic status, which is widened due to the exacerbations of these injustices beyond the healthcare sector, and can increase the feelings of isolation upon re-entry into society. Specifically, as aforementioned, the incarcerated individuals have been found to have higher rates of mental illness, chronic health conditions, communicable diseases, alcohol, and substance abuse, and thus would require adequate care. In addition, in light of the COVID-19 pandemic, we have seen the implementation of telemedicine, and while there are numerous pros to this, including the increased access of care to rural areas and continued care for patients, there are a few cons as well that we would like to address in regards to this topic. Specifically, the high implementation of telemedicine can increase feelings of isolation, specifically decrease levels of engagement with the outside world via screens that incarcerated individuals experience, and thus decreases their quality of healthcare, especially in life-threatening situations. For example, video visits, while promoting access and efficacy, can typically be a concern when subspecialties like oncology, rheumatology, and hematology are only slowly starting to be implemented now. In addition, detrimental effects of the loss of physician-patient interaction can be enhanced by underqualified or negligent care to patients that could prevent deaths, according to a study that was conducted in 2019, where at least 4 doctors were found to have one or more preventable prison deaths attributed to their care and remained on staff in Illinois prisons.
These alarming statistics came from a survey done through a Northwestern prison in which asked 15 incarcerated women about their experience with healthcare while being incarcerated. And it stated that 14 out of 15 reported that they had a negative experience, while all 15 reported that they felt as if they were treated like they were undeserving of that care.
Okay, to start off with the proposal geared towards the Department of Corrections, starting off with some current standards of care within these facilities. So typically this plays a large role in the status of the well-being on the individuals and the incarcerated population. For some funding of the 2021 fiscal year, the governor recommended funding approximately $5.4 million to treat a population of about 10,000, whom of which had complex medical concerns that are less healthy than the general population. And within the Department of Corrections, the staffing, they do have their own hires and employees, but they also do have contracted services, so this may cause some inconsistency within these facilities. Common health concerns. Many inmates enter correctional facilities in very poor health, in which the duration of the time spent in these facilities does nothing but emphasize and then further deepen these health conditions. According to a study completed by Christopher Wildman at Cornell University, each year an individual spends in prison actually shortens their life expectancy by about 2 years. Infectious disease exposure is extremely disproportionate for inmates due to the current conditions of the living environment in these facilities. And the high risk of disease transmission can be due to various factors, but isn't limited to conditions including overcrowding, poor ventilation, poor nutrition, shared hygiene facilities and items such as soap and razors, delayed diagnoses, lack of expertise in infection control, and more. And with this, COVID-19 has actually further emphasized the lack of care and resources provided for the incarcerated population. With the U.S. reporting some of the highest COVID-19 infection rates in the nation, the pandemic has just further emphasized the desperate and immediate need for decarceral strategies in order to protect the incarcerated population as well as society's well-being as a whole.
Continuing on with areas of improvement for healthcare in the Minnesota Department of Corrections. Currently, there is an inadequate system in place for chronic illnesses. In 2013, a review was done by the Office of the Legislative Auditor of Minnesota DOC's correctional facilities. The authors provided an entire list of areas that the DOC could improve upon. For one, they stated that some facilities record incarcerated individuals' chronic conditions, but that there was no policy that required them to do so. Having a system in place where all records are kept is extremely important for the health of the incarcerated individuals, especially if they are being moved between healthcare providers or facilities. It was also noted that there wasn't a current policy in place that required one facility to notify another facility if an incarcerated individual being moved had been treated for a chronic illness. These records are also incredibly important for incarcerated individuals to have as they transition back into the community and seek health care for their chronic illnesses. In 2020 and 2021, an agency profile was created for the DOC, and the current funding for the approximate 1,000 inmates was considered inadequate. Also, in the review, approximately 1/3 of the incarcerated population in Minnesota currently has a chronic illness which is greater than the whole general population. For mental illness, the DOC does not specifically screen for mental conditions when incarcerated individuals arrive at their facilities. Many of these people are not identified until after they have issues living in the facility. These individuals are placed in SLS, or also known as supportive learning services. Some mental health directors describe these SLS communities like a protective custody rather than a treatment program. Timeliness in screening and treating of women. Like mentioned previously, under the 8th Amendment, incarcerated individuals are entitled to adequate health care while incarcerated. It is hard to establish and prove violations of this amendment unless their treatment is, in quotes, so inappropriate as to evidence intentional maltreatment or a refusal to provide essential care. Timeliness of care is important for adequate treatment. The DOC requires an in-depth medical screen for all incarcerated individuals within 30 days of arrival at prison. And in 2013, this only happened for 97% of males and 18% of females. Overall, from the review of improvements outlined the Office of Legislative Auditor for the DOC could work on, many of the same improvements were seen in the plan for the 2020 to 2021 years compared to the 2013 one. This leads us to think about what improvements have been made in the 8 years since that review came out.
To formalize a partnership between the University of Minnesota and the Minnesota Department of Corrections, we propose that each party sign a Memorandum of Understanding agreement. We also propose that the University of Minnesota form a program implementation group consisting of University of Minnesota faculty and administrators that will coordinate with the Department of Corrections regarding faculty and student screening, training, and security protocols, as well as recruitment strategies, which will include informational sessions on the proposed program. They will also determine program learning objectives, schedules, emergency policies, and budgets and funding. Initially a grant-based program, over time, funding would transition from wholly to partially grant-funded and become a legislatively endorsed line item within the Department of Corrections budget. We propose a 2-track healthcare curriculum for 3rd and 4th year medical students during their clinical rotations. Students with low interest can participate in a 2 to 4 week program, while students with high interest can participate in a 4 to 6 week program. Healthcare curriculum will consist of physician observation, supervised care, assigned readings, lectures, and discussions. Students will learn about the screening and treatment of learning disabilities, addiction, psychiatric health conditions, and transmissible and chronic diseases, as well as delivery of women's reproductive care in a prison setting. The plan is to implement the Healthcare and Correctional Facilities program in one facility and expand it to other facilities if the program is successful.
There are currently many challenges present in the world of healthcare, specifically if you are an incarcerated individual in need of medical attention. To start off, one of the challenges that is currently being experienced by those that are incarcerated is the lack of access to capable technology necessary for doctor visits via telemedicine. Specifically, telemedicine software is highly advanced, requiring powerful, up-to-date computers. While telemedicine is not only cost-effective, but also much more efficient in terms of the amount of time saved from a physician not having to travel to a prison, the upfront cost of making the necessary technology to those who need it is what is serving as a significant barrier at this time. The result of this is very clear. Improper physical evaluations of patients are being carried out, and necessary discussions between the physician and patient are being cut short. Another significant challenge is the distrust seen between the patient-physician relationship. Many incarcerated patients suffer from mental illnesses and frequently are victims of sexual assault, violence, and have significant history of mistreatment from health professionals, all of which heighten the individual's feelings of vulnerability, as well as significantly hinder the ability to develop a mutual trust between themselves and the physician. The presence of trust is necessary for incarcerated individuals in order for treatments to be accepted and effective. The problem arises when physicians lack the proper training to empathize with individuals in a vulnerable population, such as those seen in prisons, and thus overall patient care is severely limited. However, if physicians are properly trained and exposed to these conditions while completing their medical school rotations, their ability to empathize with the incarcerated individuals and the gap of mistrust seen in the physician-patient relationship can be significantly improved. I would also like to add that these are only a few of the many challenges these incarcerated individuals have to deal with, possibly on a daily basis. Many recurring issues from providing quality health care to patients include, but are not limited to, insufficient community-based support services, lack of funding and expenses for community standard of care, and inconsistent electronic medical records.
Part of the mission statement from the University of Minnesota Medical School is provided in this slide, which highlights enhancing the health of people through education of skilled, compassionate, and social responsible physicians. As also stated in their mission, the UMN Medical School strives to educate medical students to serve healthcare practices in rural Minnesota through working in diverse and interdisciplinary fields. We thought this is important to emphasize their mission statement up front in the letter to Dean Toller because it allows the committee team to note the importance of fair medical treatment to all patients from unbiased providers.
The letter to Dean Toller describes the importance of this partnership and some of the benefits of it. As Tiffany mentioned, a mission of the University of Minnesota Medical School is to educate compassionate and socially responsible physicians. To fulfill this goal of educating students to become compassionate and socially responsible physicians, the medical school should focus on caring for vulnerable and underserved populations. The individuals who cycle through correctional facilities are some of the most vulnerable populations in the United States. This population is especially vulnerable because it is predominantly African American, Native American, and American Indian. So the disease burden is high, and getting care after release poses several challenges. Aside from fulfilling the University of Minnesota Medical School's mission statement, there are numerous other benefits to a partnership between the medical school and a local prison. The training program will give medical students a chance to practice medicine in a non-traditional environment, while allowing medical students to learn more about the various problems that the prison population faces. Also, since about 60% of the prison population is minorities, caring for this population could help offset racial health disparities that are present in the United States.
The vision of the Minnesota Department of Corrections is to reduce recidivism by promoting the change of incarcerated individuals through proven strategies during safe and secure incarceration and effective community supervision. In order to provide a more safe and secure incarceration, as well as to reduce recidivism, it's necessary to ensure that the healthcare needs of those incarcerated are met. This can be done through a mutually beneficial partnership between the Minnesota Department of Corrections and the University of Minnesota Medical School. The letter to Commissioner Schnell introduced who we were and how the partnership would work, but more importantly, it discussed how a partnership with the University of Minnesota Medical School would work to further uphold the previously discussed mission statement of the Minnesota Department of Corrections. Numerous case studies, one of which is actually cited in the letter, demonstrated that collaborations between academic medicine and correctional healthcare is mutually beneficial in that it provides notable advantages for both incarcerated individuals and the correctional facilities themselves. So these consisted of advancements in structured delivery of healthcare services using just evidence-based medicine. And so this included greater access to subspecialists, which was done particularly through telehealth. And it also consisted of improved clinical outcomes for chronic illnesses like cancer, heart disease, liver disease, and respiratory diseases. Another benefit that was mentioned in these studies included enhancement of trust between incarcerated individuals and healthcare providers. So according to a report done by the University of Minnesota Center for Infectious Disease Research and Policy, 45% of incarcerated individuals would actually outright refuse to be vaccinated against COVID-19. And for this, they cited distrust of the healthcare system, and just the corrections or government staff in general. These studies showed that this distrust can actually be improved by providing additional healthcare and fostering trust with the incarcerated population. With an established trust, those who are incarcerated will be more likely to get things like vaccines, which can serve to limit outbreaks of infectious diseases and prevent their spread in the correctional facility setting, as well as the communities surrounding these correctional facilities. Another benefit that was mentioned was improvement in recidivism and expenditure rates. And so because repeated arrests are often related to poverty, mental illness, and substance use disorders, allowing incarcerated individuals access to a wide range of services and clinical specialties that can be offered by academic medicine will help them to better rehabilitate. And as a result, they'll be able to return to their communities in a better manner than they had been taken in. And this is in terms of mental and physical health, which would then allow for better integration back into those societies and allow these individuals to improve their lives, especially in such a way that they do not return to correctional facilities. A benefit of this for the Department of Corrections would be a decrease in expenditures, and which just means they would have to spend less money. A decrease in people that are incarcerated would allow for a decrease in the total costs for the Department of Corrections, because that is determined by how many people are actually incarcerated. There are obviously other factors that go into this. However, the amount of people housed in these
in these correctional facilities plays a very critical role in determining these costs. And lastly, in addition to the more visible immediate benefits that I had just discussed, a collaboration between these two institutions can also be used to address broader level, broader policy level health concerns of the Department of Corrections, which would advance public health by guiding policy, development, programming, and resource allocation both inside and outside of the correctional facilities. In addition, real-time collaboration between these two facilities would actually be very helpful in better understanding evolving public health issues, such as the current COVID-19 pandemic. In conclusion, our healthcare and correctional facilities program would be incredibly beneficial for both Minnesota medical students as well as those who are incarcerated because of the way it prepares future physicians to work with an array of patients, especially those who have been incarcerated, educates physicians on the effects of prison on health, immediate and long term, and raises awareness about the intersectionality of health and incarceration, hopefully providing those who are incarcerated with the healthcare they deserve.